All right. I want to welcome everybody today. Our speaker tonight comes from Sinai Hospital of Baltimore. It's Dr. Marcie Feinman. Dr. Feinman went to med school at George Washington University and did her residency in general surgery at the New York Medical College. And then she did a fellowship in both trauma surgery and surgical critical care at Hopkins. She joined the staff of Sinai Hospital of Baltimore in 2014 and currently holds the position of vice chair in the Department of Surgery and the division chief for acute care surgery. She is also the program director for the general surgery resident for any aspiring surgeon out there who's listening and interested. You definitely would want to meet her in the future. She works in training at Sinai for future surgeons and oversees the operations at trauma surgery at Sinai Hospital. So many of you will have bumped into her on multiple occasions when you bring in trauma patients there. She also works in the surgical critical care unit and she takes care of the emergency general surgeries. She recently completed a master's in education as well as an executive coaching certification, and which she uses to help attendings and trainees reach their full potential. You'll have to work with me later. Her recent induction in the American College of Surgeon Academy Master Surgeon Educator has solidified her as an exceptional, and I agree, educator. In her spare time, she can be found with her husband, two children, and a giant Goldendoodle named Alfie. Tonight's talk will be point of care ultrasound for trauma patient. This is something that's become very popular in the last couple of years, and I'm sure all of you have seen it as you bring patients into the various trauma centers. So without further ado, I'm going to introduce you to Dr. Marcie Feinman.
Thanks, Jeff. I appreciate the editorializing also. That's always fun. I think I've given this talk before, probably a couple years ago. So if you're new, hopefully you haven't heard it. If you have heard it before, maybe you know some of the answers of things I'm going to talk about, but feel free. I'm going to try and keep the chat open too. I have a lot of windows open here, but I'll try and keep the chat open also. So if there are questions, feel free to interrupt me anytime. That's totally fine. Or put them in the chat and I'll try and get them as we go. But this is designed to be interactive. And because I do a lot of teaching, there's nobody better at just sitting and waiting in companionable silence until somebody answers my questions. So the more participation, the better. But we are going to talk a little bit about ultrasound in the trauma bay, why we use it, what we're looking for, how we use it to help us make decisions. You guys have probably seen us do it, especially in our trauma arrests. And I think it's important for you guys to understand a little bit how we make decisions, especially if it's a patient that you have been working on for a while and have worked really hard on and got to the trauma bay and we call time of death within 2 seconds of them being there. There are reasons for that. And this is a lot of what our decision making is based on. Don't really have any disclosures. There are books written purely for point of care ultrasound. So if anyone's really excited about it, you can read more than just my talk here. We're going to discuss the EFAST. The E is for extended. The FAST stands for focused abdominal sonography and trauma. It's a little bit of a misnomer because part of that looks at the heart also. Now we're going to go through a bunch of cases and I'll talk about all the decision making for the cases, but we're going to skip the critical care part, I think, for this talk because it's a little beyond the scope and then this just gets too long, but we will do all the trauma things. This lady is Grace Rizicki. She was a trauma surgeon down in Georgia for a while. When she was down there, she was trying to figure out the best way to assess patients in the trauma bay, essentially, for life-threatening hemorrhage. Because one of our big mantras in trauma is that unstable patients do not belong in a CAT scanner. And CAT scan gets very cranky if we bring patients to CAT scan and then they die in the CAT scanner. So she came up with the idea of using ultrasound, which is portable, and patients don't have to go anywhere, to try and assess some of these things. Now, the FAST looks at several areas on the body. First thing we need to do is image acquisition here. So we're looking at the cardiac window, the left upper quadrant, the pelvis, and the right upper quadrant. And then we have to interpret the images we see. So I'm going to give you some normal ones that you can kind of commit to memory right now. This is a heart. And again, we don't have to be experts in ultrasound in any way. We just have to be able to recognize fluid. So these are normal. This is a heart. Left upper quadrant, we're looking at the border between the spleen and the kidney. Pelvis, we're looking around the bladder. Right upper quadrant, we're looking between the liver and the kidney. Fluid, usually blood in our trauma patients, ends up settling dependently. And so these areas are where blood will pool if there is intra-abdominal or cardiac bleeding. And then we have to decide what to do. So these are all normal pictures, but we may get a picture that looks like this, where there's this big effusion here around the heart. Or we may get a picture that looks like this, where there's now blood, and I should be clear, the black over here is fluid around the spleen. Or we may see something like this in the pelvis, where the circle right here is bladder, and then there's blood, the black around it. Or in the right upper quadrant, we may see this big black stripe here, which is blood between the liver and the kidney. We've extended the FAST too to look at the chest. Different probe that we use, which is fine. And it goes around the 5th intercostal space, and we're looking at the pleura, both the right and left sides. Ultrasound is technically more sensitive than X-rays for picking up pneumothoraces, which is really helpful, and it can help us pick up hemothoraxes also. So let's go through some pictures and see what these look like. These are all normal pictures again. So the right pleura and the left pleura obviously look similar. They're just mirror images of each other. They kind of look, we call it like the rocky shore. It looks like a beach, where like this is the sand down here and these are the waves up here. You see a beach, that's pretty normal. Okay, again, the heart, right and left upper quadrants, and the pelvis, these are all normal images right here. Now, so this is why, so every patient that comes in, technically, every patient that comes into the trauma bay should get a FAST. Not all of them need it, but this is very, very operator dependent. So it takes a lot of practice to be really good at getting the images. And so practicing on normal over and over again is a good plan. We don't do this nearly as much as we should, but we should do it all the time. And then once we get good at it, we can focus on image interpretation, decision making. And for you guys, we're going to go through cases. There's really just no expectations here. It's okay to not know the answers to any of these or to phone a friend. Hopefully it's a little bit fun and will give you some idea of how we make the decisions we do. So, case number 1. This is a patient that you guys pick up that has a single stab wound to the left thoraco-abdominal region. On exam, the heart rate is 130, blood pressure is 94/70, respiratory rate's 18, O2 sat is 99%. You guys have intubated this patient because he's a normal combative trauma patient, and we appreciate that. You find that the breath sounds are equal and there's no external hemorrhaging. So this is where the stab wound is. Okay, it's kind of like left chest flank area. And we've decided this patient is, well, I've decided for sure this patient is unstable, right? Tachycardic, a bit hypotensive, although 90/70 is fine. Please don't push the blood pressure any higher than that. But he's not doing great. So we do our FAST, and we're going to get some videos here. And hopefully these are all playing well for you. And so as we go through this, what stands out in these pictures? Are there any of them that look abnormal? Just feel free to come off mute and let me know if you think there's anything that looks like it probably shouldn't be there.
Dark in the left upper.
Okay, so around here, I'd agree with that. Anywhere else? Also, I can't tell who spoke before, but I'm gonna call on some random people. That's always fun too. Whoever's on the top of my screen. Paul Shapiro, I don't know who you are, but your name is on my screen. Do you have a guess? Or is this one of those things where you guys like log in and disappear?
No, I'm here.
Yeah.
Uh, Again, just the dark area in the cardiac.
Okay. So you're worried about heart? Okay. Anyone else?
Left pleura looks a little funny.
Travis, okay, left pleura over here. The wonderful thing about lungs and pleura is that we have two sides. So I would tell you, at least from looking at these sides look the same, which is awesome. So probably normal, because from where this injury was, it'd be hard for it to injure both sides. So it's nice to have a basis for comparison, but the chest is the only thing we have that for. So pleura is normal. Heart's actually normal too. What we're looking at right here is like normal atria and ventricle. These are the chambers of the heart. There's nothing around the heart smushing it. That's what we're looking at when we look at the heart, at least in these cases. And we'll get to other things we look at when you guys bring in trauma arrests. I'll point out a few others though. Our right upper quadrant, see this thing just like floating in the breeze right here? Nothing should be floating around, because if it's floating, it's in fluid. So this is your kidney, and this is like liver tip, and all this black right around here is fluid. And then same with the pelvis. This is bladder, and that's normal. And then all this black around here is fluid. Now in trauma patients, fluid is blood until proven otherwise. You know, could the patient also be cirrhotic and have ascites and whatever? Sure, they could, but that's never our assumption. We are going to assume that they are bleeding. So if we have an unstable patient that we find blood in their belly, we go directly to the OR, and do not pass go, and do not head to CAT scan ideally. This patient's chest was fine, so we don't need a chest tube, and no CAT scan is required. We have enough information to know that the patient needs surgery. So that's where they go to. Case number 2, motorcycle, helmeted, going city speeds, heart rate's 125, blood pressure's 95/60, respiratory rate's 28, and O2 sat is 95%. Airways open, breath sounds are impossible to hear because it's trauma bay or you're on the highway, but his chest hurts a whole lot. Pelvis is stable, belly soft. There's no obvious external hemorrhaging. So the summary on this guy, blunt trauma, unstable. And now this is what we see here. So I'll do the lungs together because, again, we have a basis for comparison. So really, anybody who wants to speak up, do these two sides look the same?
No, they do not.
No, they don't. Which
No.
one do you think is the normal side and which one's abnormal?
I think the left looks more normal, right abnormal.
Okay. Yeah, we have this big like thing right here that's big black, kind of almost looks like a cavity, but it's not, because black on ultrasound for our purposes is blood. So we're worried about his lungs to begin with. Heart, I will tell you, is okay. And heart's always the hardest view to see, but I'll give you some good pictures eventually. This is a normal right upper quadrant. There's nothing floating. You have kidney here, liver here, and they're directly opposed, like they're directly next to each other. The pelvis is normal. This is bladder, and there's no dark black stuff around it. And then our left upper quadrant is normal too. There's a kidney in there, and there's a spleen over there. And so this patient, so now we're worried about the right chest. Now, if you want to get really, really fancy with your ultrasound, you can actually do some, measurements and tell how much blood or fluid really is in there, right? So this just shows some measurements. So just on a guess from this picture alone, there's at least 1.5 liters of blood in this chest. And that's a lot of blood. So this patient needs a right chest tube, but if we had done our measurements beforehand, we can be smart about getting blood right away and activating our massive transfusion protocols. Are you guys carrying whole blood in the ambulances yet? No, Jamie, or
Only the
No.
state police have it.
only state police. So how, if you have a patient that
So
needs it, what happened?
yeah, I was going to say it's state police, Howard County, and soon to be
Howard,
Montgomery,
okay.
and soon to be Montgomery County, along with DC.
Mike, what's the MDOs? What does that stand for? Medical duty officer. Okay. So is there just like one person that carries it, and if you need it, you have to call that person to get it?
That's correct. That's how it's operating in Howard County.
Okay.
Muted.
Well, that's
It's
cool.
still a protocol with the state. It's allowed now. This is something that's just started in the state of Maryland.
Mhm.
It's being very slowly phased in on a jurisdiction by jurisdiction situation.
Yeah. Well,
We're
I mean,
building on each other's experiences as it starts.
hopefully it'll become a win, and I know we're trying to get our like whole blood program even running in the hospital, because you know anything new always comes with red tape. So with this patient that has this big giant hemothorax, you know they're going to need blood, so get it early. That would be great. They're going to need a chest tube, and then we have some rules based on how much that chest tube puts out, whether or not they need like emergent surgery. And usually about 1.5 liters, 1,500 cc's is kind of our rule of thumb, especially if the patient is unstable. Then they need to go up to the OR for a thoracotomy, some chest surgery there. If they don't put out that much, but they keep putting out a bunch hour after hour, like more than 200 to 250 cc's an hour over the next 2 to 3 hours, that also buys them a trip to the operating room. Case number 3. This is a motor vehicle crash. Patient is belted on the highway. Heart rate's 140, blood pressure's 85/60, respiratory rate's 28. O2 sat initially was 85%, gets intubated in the field. There's bilaterally decreased breath sounds, there's crepitus, but a stable pelvis, distended abdomen, no external hemorrhage. So again, our quick summary here: blunt trauma patient, unstable. Okay, so now we're going to go through some of these pictures. And I could show you again, if we do the lungs, do these lungs look the same or different?
Somewhat different, but your cardiac is different too.
Mm-hmm. Yep. So your lungs are somewhat different, okay? This one, if you look at the right side, you see our beach and our waves here. If we're using our like rocky shore analogy, this is our sand, this is our water. In this picture, they're moving all together. The sand and the water moves together. And in this picture, the sand stays still and the water moves a little bit. And I know these are not super easy to see, but such is ultrasound. If everything's moving all together, it means that you don't have normal lung sliding, right? So normal physiology, your parietal pleura that's kind of covering your lung or is covering your chest wall, and your visceral pleura that's covering your lung is like stuck together with a teeny tiny bit of fluid in it that's like Teflon that lets your lungs slide. So what we look for in these ultrasounds are lung sliding. That's a normal finding. Every time we breathe, we want to see the lung slide. If there's no lung sliding, which is on our right side, there's no lung sliding, everything kind of moves together. That means there's a pneumothorax in there because the lung is no longer stuck to the chest wall, and so it can't slide. Other things we see. Do we see anything in the belly that is potentially concerning? Any of these 3 videos on the bottom here? Show them again.
Can I ask what the significance of the extremely bright portions are? Like we saw it in the pelvis a couple of times. The radiographs are showing us that in these quadrants as well. What does, you said darkness indicates fluid. What is the extreme brightness?
Extreme brightness is either something that's like pretty well perfused, like our kidney over here, or it's really like shadows. So anything that's radio dense will form shadows past it. That's how we use ultrasounds to look at gallstones and stuff too. So everything's kind of a difference in contrast here. And so if you have something that's like, this is going to be your liver, and then this right here is kidney, and then around that you're going to have like bowel wall and stuff, but these shadows could be rib shadows. That's very possible. One of the hardest parts to get like one of the hardest things to do on these ultrasounds, and why it takes so long and why it's so operator dependent, is where you're putting the probe, like where the structures are, is essentially through the rib cage. So you somehow have to be able to angle well enough to get like a view that's a little bit between the ribs without making the ribs just shadow over everything and hide it. So some of these pictures are not great because of shadows, but as long as you can see a little bit around it, you're doing okay. And that's what this is. You see these like radiating shadow things here. And then going back to this, since we were talking right upper quadrant anyway, and looking at that picture, there is this black right around here, which is blood. So this patient, as we talked about here, they're a little bigger. Maybe this will be helpful. Right, so this is no pneumo, where every time the patient breathes, this looks like it slides a little bit and this does not move. That's a normal finding. It's normal. And this pneumo, when they breathe, everything moves. This is moving and this is moving together. So this patient needs a chest tube and they get air, which is kind of what was expected. Is the diaphragm pushed up in both the left and the right? Sorry, I'm behind on my chat here. In this one, is that what the question is? It's super hard to tell if your diaphragm's pushed up because you don't really see it here, and you don't know. These pictures don't show you, you don't know where externally on the body the probe is. So this could be pushed up really high if they're going all the way up like armpit area to get their pictures. But just by looking at the ultrasound imagings, we have no idea like the height and where they are. More in the left and right pleura. No, I don't think so. I think you have a pretty normal amount of like lung tissue and diaphragm on these. I wouldn't say this is particularly pushed up in terms of diaphragm, but those are good questions. Okay, so we get our chest tube in, great. We get air out, which is expected, no blood, cool. And then there's a repeat set of vital signs that shows a heart rate of 130, blood pressure is 90/70, respiratory rate's 28, and the O2 sat is 100%. It was 85 before, so we fixed that part. What else does this patient need? Any thoughts on what else we need to do for this guy? Are we going to call this stable or unstable with these vitals? Unstable, yeah, okay. And what other finding was there on that fast that would help us decide what to do with this unstable guy? What did we talk about over here? Right upper quadrant blood. Yes, thank you. So agree. So we fixed one part by putting our chest tube in. But if he remains unstable and we still know that there's blood in the belly, then he buys himself a trip to the operating room to see what's going on there. The next patient has a single stab wound to the right anterior chest. Never a good plan. Heart rate's 130, blood pressure's 94/70, respiratory rate's 18. He's satting okay. Also comes to us intubated with equal breath sounds and no external hemorrhage. So this is his stab wound. We have what we call the cardiac box, which is our clavicles superiorly, nipple line laterally, and then bottom of the rib cage inferiorly. And anything in there, we consider the cardiac box. We worry about the heart. And this guy obviously is a penetrating injury and is unstable. So now if we look at his lungs, these ultrasound pictures look the same on both sides. But what's wrong with his heart?
It doesn't look right.
No, does not look right, which, you know, sometimes that's all we really need to know is that it doesn't look right. So this line over here, I hope you guys can see my mouse, but this line over here is your pericardium, right? So sac the heart sits in, and then all this black right here is a pericardial effusion, right? The problem with the pericardium is that it has zero give, right? It doesn't stretch in any way. So if you get blood there, the only thing it can do is smush the heart. It's the only place it has to go. So this is a very smushed heart. And as Dr. Sagel very astutely pushed out, it's not happy. So thanks for that, Jeff. The abdominal pictures tell you are normal, which is, I mean, unless this guy got stabbed with a machete, pretty much what we'd expect based on where the injury is. So the question is, what do we do now? This is a different view of a heart also with what we call tamponade, where there's so much smushed heart that the atrium and ventricles can't expand, so then they can't contract. So we have to decide what to do. And like way back in the day, we used to talk about doing pericardiocentesis, where you stick a giant long, like this long spinal needle right up under the xiphoid and just aim towards the left shoulder and pray that you don't actually stab right into the heart, but only get the fluid around it. We don't do that anymore. So now we actually have to go operate and open the chest in some way. If the patient is super unstable, is too unstable to even get to the operating room, then we'll open the chest in the trauma bay. And if we ever open a chest in the trauma bay, it is always the left side. It gives us the best access, at least based on left or right side, but this gives us the best access to the heart and the aorta, because sometimes we need to clamp the aorta too. So we always go left, but ideally, this patient, if they can make it up to the OR, then they need a sternotomy. We need to just go right through the sternum, which gives us much better heart exposure. And I think Jeff and I did one of these like a few weeks ago on somebody for pretty much this exact reason. Although it was a gunshot wound, not a stab wound. Case number 5, as we continue. Patient, again, single stab wound, anterior right chest. Now the heart rate's 75, blood pressure is 124/70, respiratory rate's 12, O2 sats 99%, airways open, equal breath sounds, and there's no external hemorrhage. So this, in terms of scenarios, is the first one we have that shows a stable patient. Okay, so that's a good start, but it's still in the cardiac box, so that's never really great. And if we look at our pictures here, we look at our right and left chest again, they look the same. How about the heart? Is this heart normal?
Yeah.
It's almost normal. It's not quite as abnormal as the other one, but there's still a tiny bit of fluid right here. This little black stripe, little bit of fluid. Now this one's not being smashed like the other one. The other one was like very obviously unwell. Our rules, kind of, well, they're changing. Our current like society guidelines say that if there's, penetrating injury and any kind of fluid around the heart, we're required to investigate it further, usually with something surgical. Now these days, we'll tend to do more formal echocardiograms if patients are stable before we run to the OR. But we would fail our certification exams if we didn't say that this patient had to go to an OR and actually open the pericardium in some way and see what's there. Case number 6. We still have a single stab wound to the anterior right chest. Patient stable. There's no external hemorrhage. And this one, if we look at this heart, this is a normal heart. There's no stripes of any kind of fluid around that. And I'll just tell you that all the rest of them are normal too. So this patient has a fully normal ultrasound fast exam. And there's a few options here. Most of us would, since this is so operator dependent, we'd probably admit and observe and get an actual formal echo to really make sure that there's no fluid there and we weren't just mistaken or didn't get a good view. But if that's negative, patient can go home. There's a couple caveats to that. If patients also have a left hemothorax, they're bleeding into their left chest, that ultrasound of the heart will not be accurate because they can bleed into their pericardium too. And it can, if there's a little hole in it, it will decompress into the left chest. So you may miss the cardiac injury. And also if the patient has had heart surgery before and a median sternotomy, that can make these images unreliable as well. This was not my patient. This was somebody I know's patient. What do you see? Can anyone even tell what we're looking at? I'll give you one more view in a second. Now can you tell what we're looking at? hopefully.
Nail gun injury?
Yeah, yikes. And there's a couple really important things on here too, at least for us in terms of decisions. So, okay, he's got, if I go back to that other picture, so this is what we see from the outside. This is it. And then this is the x-ray. And the other thing we have to notice are these things. What are these things right here? Anyone know? Yes, Philip, yeah, and Carol, yeah. So these are sternal wires from a previous sternotomy. It's very important for us to know because there's going to be all kinds of scarring. Now, in our decision making, sorry, let me go backwards a little bit, right? The best thing for us to do if we're really worried and need to like do something surgical would be a sternotomy. That's where this location is. But going through an old one, much more challenging than otherwise. So they did a fast. This is the heart. And the fast was totally normal. Nothing weird about it at all. They didn't see any pericardial effusion. They also did a formal echo. This is transesophageal echo is what TEE stands for. So that's kind of like our gold standard of echoes. Also didn't see any pericardial effusion here. Patient's stable. So, yay, that's great. However, you couldn't just like hang out with that nail forever. It still needed to come out. The decision was made to do this in the operating room and not just pull it out in the middle of the ED. So he went to the OR and they specifically thought about it and did a thoracotomy. So they went through the left side of his chest instead of going back through that sternum because he'd had that surgery before. This is a video of part of it. This is the clamp on the nail right here. And you can see that it is beating. So it's really a good thing that they did not pull this out in the trauma bay or in the ER. They went to the OR, they put a stitch and a purse string around that and then pulled it out and tied it. And the patient did fine.
Yeah, you need to take the tension off. So
one more time.
Thank you.
Okay. So again, we talked a little bit about the cardiac box. Oh, there's my doggo. Injury to the cardiac box, patient's not stable. Great. Those are really easy. We have to do something surgical. So if they're like dead or really unstable, they get an ED thoracotomy. If they're not dead and we have the ability to get to the operating room, they get a sternotomy. If they are stable, then we get to start doing some imaging. So we can look with our own ultrasound, our point of care ultrasound, and then we can get a formal echo if we need to. And if there's fluid, we need to look somehow. We do what's called the pericardial window. And if there's no fluid, awesome, and we're done. Next scenario, and I think we only have a few more to go here. This is a motor vehicle crash. Patient's not belted, going city speeds. Heart rate's 80, blood pressure is 135/60, respiratory rate's 28, and oxygen saturation is 95%. Airways open, breath sounds are equal. Abdomen's pretty underwhelming. So this patient is blunt trauma stable, right? We see lots of these all the time. And so we do our fast. And does anybody see anything weird on any of these pictures? Sorry.
Fluid right upper quadrant.
This one?
Sorry, I hit the wrong button on my phone. Yeah, is that not what I'm seeing right there is fluid buildup?
No, what you're seeing right here is a kidney. This thing's kidney. So the black is like the fluid in the kidney. So that's like,
Mm.
you know, collecting tubules, urine, all that kind of stuff. So that's normal looking stuff. This is liver right here. And they're like smushed smack against each other, which is good. That's what you want to see. So no blood there. So this, by and large, is an essentially normal fast. Nope, bladder's normal. It's just full. Patient has to pee, but it's all well circumscribed in the bladder. There's no dark stuff around it, so no blood around there. And that's fine. Tons of our patients have normal fast exams because you have to bleed a substantial amount in order for it to pool so you can actually see it on ultrasound. So if we have a patient with a significant mechanism of injury, right, our motor vehicle collisions, our falls from heights, pedestrian struck, with a negative fast, we need a better way to see what's going on inside. So those patients, when they're stable, go to the CAT scanner. There's a lot that fast can't see. It can't see like extraperitoneal pelvic hematomas. It can't see retroperitoneal hematomas. It also can't see actual organ injuries, right? So all it sees is fluid. So this, what we're looking at on screen right, this over here is a liver with a pretty substantial right here laceration down it. But if this is all contained within the liver capsule and doesn't bleed outside the liver into the belly, FAST won't show that in any way. Same with this other side. This is your spleen right here with a big crack going right through it like this. That's also, there's no real surrounding fluid. So our FAST exam won't pick those up. So we do still need to do workup. We need to get our imaging and CAT scans. With these kinds of solid organ injuries, this patient would buy themselves an ICU stay, but not necessarily an intervention or operation. Is ultrasound ever used on the posterior to look at the kidney area? Ultrasound won't pick up anything retroperitoneal particularly well. So kidneys are retroperitoneal organs. So for our purposes, we don't use them. Now, is kidney ultrasound a thing? Yes, it exists, but it's usually used to look for tumors, for masses, for things like that. We don't use it to look for injuries or trauma. With the liver laceration, wouldn't you have hemorrhage as well? It depends. The liver and the spleen are both kind of within a capsule. So you can crack the liver intraparenchymal within that capsule, or have what we call a subcapsular hematoma. So you can have a big like hematoma, but if the capsule's still intact, you won't have free fluid into the belly, which is what our ultrasounds are picking up, is the free fluid area. So CAT scan's useful. We love CAT scans. Okay, and perhaps our most important, I think this is my last scenario for now. This was my Saturday night. I don't know if any of you brought me this patient, but thank you very much. This was a patient that came in, multiple gunshot wounds to the chest and or abdomen, I don't know, take your pick. CPR in progress, right? Sadly, we all see a lot of this in Baltimore. So obviously heart rate 0, blood pressure 0. Patient is intubated, thank you very much, and being bagged, comes in, needle decompressed bilaterally, stable pelvis, flat abdomen, and no obvious external hemorrhage. So our summary here, penetrating trauma, patient's dead. Things that we need to do, obviously, and you guys do this too, we have to ensure the endotracheal tube's in the right position. Old school, we used to say nobody in trauma was allowed to die without bilateral chest tubes. That was like a rule. It was a mantra. And I don't know how long some of you have been doing this, but if it's, you know, like as long as I've been in practice and training and stuff, you might have seen that a whole lot in the past, that like every trauma arrests that came in got bilateral chest tubes immediately. We don't do that as much anymore, but nobody would fault you if that happened. And then ACLS. So some of our decision making at this point is based on how long since injury, how long has CPR been ongoing, right? You guys, I'm sure you're all familiar or get asked this anytime you bring a trauma arrest in, you know, like how long has CPR been going? And most of you are super good at just telling us when you roll in, it's been 15 minutes. It's been however long it is. My Saturday night patient, I asked too, it had been 15 minutes. Patient was in PEA the whole time. So then I was kind of wondering when the call went out, just to get an idea of duration. So for us, really, if it's more than 15 minutes, the chance of like meaningful recovery is pretty much zero. If it's less than 15 minutes, this is where our ultrasound comes in very handy. There was a study done back in 20-something, 16-ish maybe, in California that we kind of now all use for decision making. And what this study showed was that if you put an ultrasound on the chest to look at the heart, and there was no cardiac motion, no organized movement, even with PEA or something on the monitor, the chance of recovery was zero. And so we use that pretty often to make our decisions now. So at least our team, if we have enough warning to like get down to the trauma bay before the patient's wheeled in, which sometimes is 50-50 depending on where we are and the ETA, you know, we have somebody pretty much responsible like for the ultrasound. That's their whole job, is to make sure it's like on and functional and has goo and all the things. And that's what we're looking for. Our challenge, at least our biggest challenge here, is now like the universal use of the Lucas device, which is amazing and does great compressions and frees everybody up and it's awesome. And we can't get our ultrasound at the same time. So a lot of times, at least for us, if you bring us patients that are in arrest, we are going to ask probably pretty early on to take the Lucas off so that we can actually get a view and see if there's anything going on. If there is no motion, we're done and we'll call it, even if they've been in the trauma bay for 30 seconds. And if there is motion, then we'll do some other things, blood, etc. So those are my highlights. The eFast, it is repeatable. You don't have to move patients, so they can stay where they are. If a patient's hemodynamics change, like we're working on them and they're doing okay and we do their fast, and then all of a sudden they get sicker, they get tachycardic, they drop their blood pressure, you can just do it again. You don't need to do anything different. So we just do it again. And it helps us make decisions for whether patients need to be in the OR immediately, or do we have time to go to the CAT scanner to let them look around and do their thing. And that, I believe, is the end of what I have for slides, but I am happy if there are questions or anybody wants to talk about anything that's not necessarily fast. You know, let me know, and I'm happy to answer whatever you got.
Well, thank you. First of all, very informative. Where do you think we're going with ultrasound in the trauma patient at this point?
I don't know.
It's
You know,
not been
I'm
out for a few
wondering.
years.
I feel like because so much stuff's being moved to outpatient also to EMS, and there's you know, the butterflies you can just hook up to your iPhone and you can like have an ultrasound. I think that it'd be a neat tool for EMS to carry also, especially for to look at the chest, you know, even more than anything. Andrew, there's like 100 people looking at you right now.
Awesome.
Yeah. So we get for late at night at home talks. But, you know, I think it would be super useful because we were just, I mean, I saw Jamie's comments in here too, like the current EMS practice for trauma arrests and get bilateral decompression kind of standard. I think, again, that's not a bad thing, but having like one of the butterfly ultrasounds available just to be able to look and see if there's actually a pneumo or not, I think that would be very useful information. I don't make the protocols, but I could see that
I'm on
being
that committee.
in the future. Yes.
It's
You do a
interesting.
lot of ultrasound, Jeff, so.
Yeah, it's interesting, especially the ultrasounds, because you can use that to help with IV access. You can, I mean, it's a way to look under skin anywhere. And the butterflies, we have a few of them up in the OR, although we're using mainly for line placement at this point.
Yeah, we have the ICU too that we use for that.
Because the devices we have are much better than the butterflies because they are limited. But I think you're right. I believe it's coming, and a butterfly will take a quick look at the heart, for example, from a subxiphoid approach, and you can see if you're at least moving blood or not, and that can help in fields and in the future. So and the technology is only getting smarter at this point, and I mean it's affected American College of Surgeons ATLS recommendations over the years, and so it will be interesting to see where it goes in the next 5 to 10 years.
Yeah, I agree. Technology is cool. This is like a total random aside and not related to point of care ultrasound in the slightest, but I have this mentee who's a surgery resident in Kentucky. Her name is Brittany Levy, and she wants to be a colorectal surgeon, not trauma. But she has a patent right now for a tourniquet that works kind of like an AED. Like you put it on and you turn it on and it talks to you and it tells you, like, it has sensors that tell you how tight to tighten it, and if it checks it every few seconds, and if it gets loose, it'll tell you to retighten it and automatically record the time that it's on, occlusion time and stuff. And I really hope that she makes that a thing, because I think that's awesome. Yes, body habit is certainly a consideration in the efficacy and accuracy of sonography, especially kind of the ones that we were talking about, like some of those, the butterfly, like the portable ultrasounds and stuff aren't phenomenal. They're fine, but they're not great. Like the big ultrasound machines are better because you can change depth and gain. So if somebody is much larger, you can change the depth of where you're looking at, which helps overcome some of that. It's not great. Like the deeper you go, the grainier the pictures and stuff like that. The gain makes it brighter or darker. But yeah, so the fancy ultrasound machines do have some ways to try and overcome some of that, but it won't be perfect. But you can see what you need to see. Any other questions? I feel like I hit most of the chat when I was like, through.
Hey, Marcie, and thank you for recognizing my chat or my comment. And it was about needle decompression, because sometimes we still have patients that come in and have it kind of second intercostal space, mid nipple line. And it was nice to see somebody responded that, I think if I'm not mistaken, it's moving fifth intercostal space mid-axillary, which I think the evidence shows that it's much more effective than previous practice. And I'm interested to hear from our EMS colleagues if this has made a difference, or if this is now becoming more common practice.
Any takers? I can't answer that one.
I think when we look at the total statistics for the various jurisdictions, there's not a lot of needle decompressions that have been going on. I don't know if it's just because of fear or, um, you know, pneumos cook over time, as you know, they're seeing patients within the first 15 minutes, and as opposed to by the time they arrive at the hospital at like 30 or 45 minutes when they become significant at that point. I mean, some are being done, yes, but I don't think there's a lot of that being done in the field at the moment based off of the EMS reports, the Maze reports.
I feel like I see like a fair number. You know, the data. Oh, that's a good point. Can't do mid-axillary if the Lucas is on. That's something to take into consideration. The pros and cons of the Lucas right there. But
I'm a big supporter of the Lucas.
yes, I'm aware. As well you should be. You should be their poster child. You know, the reason that it switched is because the data showed that when it was the second intercostal space mid-clavicular, it was only actually in the pleural space 50% of the time. So not great. And they get a slightly, you know, a higher percentage in the fifth intercostal space. But yeah, I get there are restrictions here, like the Lucas, obviously. I don't know how to answer or what this comment is. Trauma in early and late stage pregnancy. If you want me to talk all about trauma and pregnancy, I feel like that's probably going to have to be a different talk. But if there's something specific or that I can answer, I'm happy to.
The Goose hamburger.
Broader surgical questions. TXA have a role. Oh man. That is a great question because we are in the middle of talking all things TXA right now. I would say, so to that specific question, TXA a role in the observed patients with a slow bleed not indicated for immediate OR? I would say no. TXA is not without, you know, some complications, especially thrombotic ones, and we always worry about clots in patients. And we have and Jamie will be very excited that I mentioned this, but we also in the hospital then have the availability to run a TEG. Do you guys know I don't know if you guys know anything about TEGs, but we can talk about that at a different time too. But TEGs are very cool. Stands for thromboelastography. And it shows, it gives us like a picture and some numbers associated with how well patients form clots. So this TEG, which runs pretty quickly, can tell us what specific blood product patients need if their blood's not functioning normal. So it'll tell us if they need red blood cells, it'll tell us if they need platelets, it'll tell us if they need TXA, and it'll tell us if they need plasma. So I wouldn't give it empirically if a patient's like, if we're just observing, it means they're stable enough to observe. Before we just give TXA carte blanche, we'd probably run our labs, our TEG first and see if, you know, if that's something that's needed. Anything else?
That was my first time seeing sternal wires. I was
Yeah.
wondering if you kind of expected that, having like once you pointed it out, I saw the scar midline across the sternum. So I was wondering if you expected it, and I'm also wondering if they're actually palpable under the skin or if they more run through the bone.
They are not. I mean, unless your patient's pretty emaciated, they should not be palpable under the skin. There are still a few layers of like kind of like muscle and fat that gets closed over them, and the wires. So yeah, we get kind of like good at looking for scars. I feel like that's just like something we zone in on. So anytime you see a midline, like we see a midline chest scar, I would expect sternal wires for sure. There's no other way to close a sternum. If there's like if there's a mid chest scar that goes up and down, pretty much 100% of the time, that means somebody's sternum was opened and there's no way to close it other than with wires. There's nothing that's not radio opaque. So, yeah, and they really are, they're metal wires with a really sharp needle that you put right through the bone on either side of the sternum. And then you have a clamp thing that you like twist them around and it gets super tight. And then you cut them with like wire cutters pretty much, and then bend them down so that they don't like stick out through the skin so you don't feel them. And that's what you do with wires. But yeah, mid-sternal incision, almost guarantee there's wires under there. I know we're past 8 and I don't know like what the timing is, so I can certainly cut off here. If there's more
Yeah.
questions I can answer, it's up to you, Jeff.
Well, no,
I'll put my half-naked kids to bed.
we saw. Thank you very much for coming tonight. It's definitely the future. It's the present and the future in trauma. So no, I appreciate it. We appreciate hearing from you again, and I thank everyone for showing up. We're planning on being back again on the 2nd, and again we're following the 2nd and the 4th Thursdays of the month. So
All
thank
right.
you, everybody.
Good night,
There's a
guys. I will see
sign-in.
you in the trauma bay.
Yeah,
I'm gonna go.
absolutely. There's a sign-in for people who want to get for CME or CEU in the chat, and we'll keep the link open for a little bit. But thank you for attending.